Welcome to Clinical Minute. RW is a 35-year-old recent Muslim immigrant from Ethiopia. She and her husband are both living with HIV and have come together for RW's visit. The health department referred her to your community health center during her immigration process. Since she does not speak English, you are using language link interpretation services on the phone to speak to her in her native language, Amharic. She mentions that she has not had access to her HIV medications for a couple of months during the move and transition. She says she feels well without any fevers, rash, headache, abnormal vaginal bleeding, or GI symptoms. She had an undetectable viral load in Ethiopia on her 3-pill regimen, which she is able to identify on a pill chart. You inform RW and her husband that it is your practice to see all patients individually. Her husband can wait in the waiting room, and RW will join him after her visit. You tell RW and her husband that you are able to take care of both her HIV health care and her general women's health care. She will get blood drawn today to assess her HIV labs and talk to a social worker about housing, transportation, and other health issues. You ask RW if she's ever had a test for cervical cancer. She responds that she's not sure. You go on to ask RW and her husband about their knowledge of cervical cancer. You tell them that almost all cervical cancers are associated with ongoing infection with HPV, the human papillomavirus. You know that 70% of cervical cancers are from types 16 and 18. You discuss how cervical cancer develops, who is at risk, how HPV is transmitted, and the screening recommendations. RW says that she doesn't need screening because her husband doesn't have cancer, and neither of them has been with anyone else. You use an anatomy poster on the wall to point toward the cervix and explain that regardless of any past sexual history, RW needs screening because having HIV puts her at risk for cervical cancer. This helps them both understand the need for screening. You all agree to have cervical cancer screening done on her second visit. You know that the lifetime risk of HPV infection is about 75% for sexually active individuals. You are also aware that new diagnoses from cervical cancer have declined over the last 40 years due to the availability of effective screening, and that the overall death rate for cervical cancer has been falling. You recall that screening rates in the U.S. are below the 93% target rate set by the Federal Healthy People Objectives. In 2013, the overall screening rate was 80.7%. You know that the disparity between the target screening rate and the actual screening rate is due to factors that can affect all women, such as health insurance access, educational level, financial stability, personal beliefs, prior trauma, and how patients feel about their medical provider. You also know that cervical cancer incidence and mortality disproportionately affect certain vulnerable and underserved populations. Patients who are Hispanic, non-Hispanic Black, American Indian, and Alaska Native have higher rates of incidence and death for cervical cancer compared to non-Hispanic white patients. You recall reading that Black women born in Eastern Africa have cervical cancer rates of up to 34.5 per 100,000 compared to African American Black patients in the U.S. who have a rate of 9.4 per 100,000. In addition, according to National Health Interview study data from 2008 to 2010, African American women were more than 3 times more likely to report a Pap smear within the last 3 years compared to African-born women. You know that these differences in screening and cancer rates reflect a lack of access to equitable treatment due to a variety of socioeconomic factors, language and cultural barriers, and personal beliefs. You are aware that the barriers to screening facing racial and ethnic minorities include lack of citizenship or documentation and lack of health insurance are difficulties some minorities face in accessing affordable and culturally sensitive care. language barriers, and level of acculturation. In general, higher screening rates are found once there is greater acculturation as measured by the number of years in the United States and speaking English. Lack of knowledge. Not all women are aware that HPV causes cervical cancer and that it is sexually transmitted. Some also believe that cervical cancer screening is not required if they are not sexually active. Cultural beliefs may also influence care-seeking behavior. For instance, some Hispanic women may be influenced by cultural fatalistic beliefs that having cervical cancer is predetermined or punishment, and that the outcome can't be changed. Mistrust of the medical system due to fear of being stigmatized or mistreated due to race or ethnicity. Prior sexual abuse and intimate partner violence can also keep women from seeking screening. You know that the number one thing you can do for your patients is to recommend cervical cancer screening. You also remember, calling patients to confirm their appointments and answer any questions they may have increases the screening rate. Using peer navigators, lay health educators, and clinicians of similar race or ethnicity and gender as your patient population have been shown to increase screening rates. Eliciting and discussing patient beliefs about cervical cancer and normalizing cervical cancer screening help patients understand the value of screening. Utilizing medical interpreters rather than family members for translation respects patient privacy and helps deliver unbiased care. It is recommended that educational sessions be conducted in gender-specific groups led by health educators of the same gender. This respects those from conservative cultures by creating environments where people feel more comfortable addressing sensitive educational information about women's bodies. It is also recommended that cultural and religious values be incorporated when developing education programs for male family members. Utilize female clinicians when possible, because modesty, distrust, and cultural taboos may hinder women from feeling comfortable with male clinicians. Conduct community outreach where your target population congregates. Identify affordable community health resources where you can refer patients needing follow-up. The CDC's National Breast and Cervical Cancer Early Detection Program, federally qualified health centers, and health departments serve low-income, uninsured, and underinsured women. You know that HIV-positive women have a higher risk of multiple HPV infections, a higher persistence of HPV infections, and an increased risk of progression to precancerous or cancerous cervical lesions compared to women not infected with HIV. The prevalence of abnormal Pap tests among HIV-positive women is 38%, with about 20% being ASCCP. The prevalence of HPV is higher and progression to CIN is faster as CD4 counts drop below 500. About 20 to 40% of women living with HIV are not screened appropriately. Available data are not clear as to whether people living with HIV who are on antiretroviral therapy and are undetectable have lower rates of cervical cancer compared to people with detectable viral loads. Further research is needed to clarify this point. You know that women living with HIV face additional barriers to screening. Cervical cancer screening becomes a lower priority when faced with acute health crises. Women are less likely to be screened when their HIV care and gynecologic care come from different providers. Additional medical appointments and the need to find and build trust in a new provider decrease the likelihood of preventive screening. Substance use and severe depression, often seen in women living with HIV, contribute to lower cervical cancer screening rates. Pain and discomfort with prior Pap smears has also been found to correspond to lower screening rates among women living with HIV. You remember that the panel on opportunistic infections in HIV-infected adults and adolescents published cervical cancer screening guidelines in 2016. The American College of Obstetricians and Gynecologists, or ACOG, subsequently adopted these guidelines. ASCCP also published guidelines. The new guidelines reflect a move away from annual screening based on a balance of the cervical cancer risk and cost-effectiveness of screening. They also include HPV co-testing for those older than 30. Those younger than age 30 are screened with cytology only or reflex testing. For those younger than 30, the initial cervical cancer screening should be done after 1 year of the onset of sexual activity, but no later than age 21. Those older than age 30 should have a baseline PAP at the time of HIV diagnosis. There is currently inadequate evidence to recommend stopped screening at age 65 as recommended for HIV-negative persons. Even if the cervix has been removed, vaginal screening is still recommended to screen for cancer. RW returns for her second visit, which goes smoothly. Given her HIV status and age, you co-test using a PAP and HPV tests. You schedule an appointment in 1 week to discuss the results. A few days later, the PAP test result comes back and is LSIL with HPV high-risk positive. You document her test findings in her health record. You recall that the panel recommends that most women living with HIV who have ASCCP go to colposcopy. The exceptions are when HPV testing is positive, but the genotype-specific testing for HPV-16 or HPV-16-18 is negative, then repeat co-testing in 1 year is recommended. If the co-testing finds that the cytology is abnormal or the HPV is positive, then referral to colposcopy is recommended. When HPV testing is not done or is unavailable, then the recommendation is to repeat the cytology at 6 to 12 months. If the result of that repeat PAP is ASCCP or greater, the panel advises proceeding to colposcopy. All women living with HIV who have LSIL or higher should proceed to colposcopy regardless of HPV results. You remember reading that ACOG and ASCCP differ from the panel in their recommendations for women between the ages of 21 and 24 with ASCCP or LSIL. They recommend following the ASCCP guidelines for HIV-negative women and not proceeding to colposcopy even if the high-risk HPV test is positive. When HPV is positive, they recommend cytology at 12 months, and then repeat cytology in 12 months if NIL, ASCCP, or LSIL is found. For ASCH, AGS, or HSIL, colposcopy is recommended. ACOG and ASCCP reached this decision by weighing the high prevalence of HPV in this age group with the lower incidence of cancer. Conservative management allows time for the immune system to clear the HPV. ACOG also states that women living with HIV who receive regular screening and recommended follow-up treatment have a similar incidence of invasive cervical cancer compared with women who are HIV negative. Lastly, you know that ASCCP and ACOG agree with the panel in that LSIL diagnosis in women 25 years and older should receive colposcopy. However, if there is a negative HPV test, they prefer repeat co-testing at 1 year. ACOG specifically agrees with the panel in that any women with LSIL above 24, regardless of HPV result, should get colposcopy. ASCCP and ACOG agree with the panel that all women, regardless of age, with ASCH, AGC, or HSIL, receive colposcopy. When RW returns to your health center, you explain her test results and tell her that you recommend a colposcopy to look more closely for abnormal cells so they can be treated if needed. You go on to explain what a colposcopy is, what to expect, and possible treatments for any abnormal cells you find. You ask if she has any questions, and she said she does not. Before she leaves the health center, you provide her with written materials about colposcopy in Amharic.